Great, thank you very much. And thanks everyone for coming. This is a very important moment for certainly the evidence team, but I think the whole Early Intervention Foundation. We've spent a long time since Graham Allen set the organisation up reviewing this evidence that we're now launching and presenting to you. And we've taken a long time because we've been very careful. And we've been very careful because the nature of this evidence really matters. The effectiveness of the early intervention ultimately depends on the quality of this conversation. The degree to which we're able to communicate meaningfully what the evidence means. I've worked in a number of roles in universities and civil service. People like the idea of evidence-based policy. There's a simple idea that the evidence can just kind of tell you what to do. And we all know that it's not as simple as that. The evidence can inform practice. The evidence can inform commissioning. It can be part of the way in which you think about the work that you do. And that can only work if you understand what the evidence can really say and what it can't say. So the nature of this conversation really matters. And what we've spent a long time trying to do is get the right balance between certainty and uncertainty. It's too simple to think there are some interventions that work, and if you just commission those ones, everything will be all right. And there's some other things that don't work, and you should just not commission those ones, and everything is very simple, and children's lives will be transformed. You all know that the reality isn't as straightforward as that. And so the challenge is to say, well, what can you learn from the evidence? Because the evidence does inform. There is a tremendous wealth of information in the review that we published yesterday. We've looked at 75 programs of a particular type. I'll tell you about the type in a moment. We looked at 75 programs that are available to commissioners in the UK. And this review is unusual because normally what systematic reviews of evidence on what works do is they look at the best evidence from around the world. And they tell you, wouldn't it be great if we had that program that worked brilliantly in these 14 sites across America or in various other parts of the world? And what would be the benefit? People estimate the benefit of introducing those programs without regard to context and implementation. What we've done in this review is look at the programs that are available in the UK. And we've asked, what is the evidence underpinning those programs? And what can we learn from that about how to advise commissioners about how to improve commissioning so as to improve outcomes for children and families? So the standards of evidence, what I'm going to talk about now, are what do our ratings mean? When we talk about programs and we try and summarize in simple terms the evidence underpinning these programs, what are we actually able to say? What can you interpret from what we're telling you today? And I'm just going to talk very quickly about the background to it in terms of the ratings and what they mean, what the scope of the review has been, why we've focused where we focused, and then my colleague Kirsten Asmussen, who is really the expert in the programs and in the underpinning theories, is going to describe in a bit more detail some of the more detailed findings. But this is a massive program of research, and the reality is in 20 minutes we can just introduce you to the material, and the challenge for us is to find ways of engaging you in the material such that you can read it and you can think about the relevance to your practice and your commissioning. And so we've got a range of documents. There's a report, there's also a commissioner's guide, there's a document that describes the evidence on every one of the programs, and so various materials, and I'm just going to just try and describe as an outline why we've looked at what we've looked at. Ultimately, the evidence can inform, but it's how you use the evidence that is going to make the difference. So, as Kerry said, we have our Early Intervention Foundation guidebook. It's available on our website, and you can search it to find, at the moment, 50 programs that are available in the UK in terms of the outcomes that they've been shown to have impact on. In this version of the guidebook, as Kerry said, we've taken evidence. There are a range of organisations around the world called clearinghouses which rate programs, and they present that information for different audiences. But there are about 15 or 20 of these clearinghouses. So what we did is create a framework by which we can present all of that evidence in a straightforward and single framework, and that's available in the guidebook. What we've now done since is start to assess programs ourselves, and we've had to do that because most of the clearinghouses are elsewhere. They're not looking at local practice, they're not looking at UK programs on the whole, and so they're not able to assess the quality of the evidence underpinning most actual practice. They're just talking about the best evidence programs. So we've started to assess a much broader range of programs, and that information will be introduced into the guidebook. But I really want to make the connection between the guidebook and the work Kerry described last year, where we looked at the cost of late intervention. So in England and Wales, the cost of spending on late intervention is roughly £17 billion a year. The important thing about that number is that's not the long-term cost, that's not the intergenerational cost, it's not the economic cost, it's not the social cost, it's just the immediate cost to taxpayers of activities that have to happen because children's lives have taken pathways that require statutory or acute intervention. The long-term implications of that cost is enormous, would be in hundreds of billions. This is just the immediate cost, and we estimate that to be about £17 billion a year. As Kerry says, not all preventable, but a lot of it is preventable. And the point of the guidebook is it makes the connection between the programs that are there that can improve lives for children and families and the reductions in those needs for late intervention. And that's a really important part of the rationale for what we do, which is why in this review, major review for the Early Intervention Foundation, we focused on this issue of parent-child interactions. We've done that because, as Graham Allen emphasised very heavily in his review, creating intergenerational change, supporting improvements across generations means treating causes and not symptoms. That's what early intervention is about. But when you're looking intergenerationally, what is a symptom for an individual becomes a cause for the next generation. The quality of the interaction between the parent or primary caregiver and the child is the primary external driver, external to the child, the primary driver of the development of the child. I say external to distinguish that from the genetics and what the child inherits and brings to that interaction. But what the genetics does is stimulate the child to interact. The child is introduced into a world as an interactive agent. And the supports and the enablement and the scaffolding that the child has in her environment is central to the way development occurs, and then it gets programmed back into the child in an ongoing series of interactions. So if we want to enable children to develop and have better lives, focusing there we think is very important. That's the essential driver, rather than all the sort of extraneous features around, although that obviously always happens in a context. So we've focused on parent-child interactions because that's where, in a sense, the biggest benefits can be achieved if parents and carers can be supported to provide the support for child development. And we focused on these three outcomes: attachment, behaviour and cognitive development. Obviously all of that is on a sort of a substrate of physical health and development, of medical health, obviously vital to the developing child. But these three features go beyond what people sometimes think of as school readiness, attachment being the sense of relationship that the child has with the primary caregiver and the basis on which so much development occurs, behaviour, how they then interact with the world, and cognitive development, how they're able to think. Those are building blocks for life chances in a very fundamental sense. So this seems like a very sensible place to focus if we want to use resources effectively. I need to just emphasise what I'm going to talk about now and what our ratings are about is the strength of evidence behind these programmes. We're very well aware that what people are involved in is sometimes system change. People are very interested in practice, but we can learn a lot from these programs, either by commissioning them or just by using them to understand what the evidence tells us. The evidence about programs is very strong. So the strength of evidence rating matters a lot. But obviously what is going to be most effective locally needs local cost-benefit analysis. What are the local population needs? And what is the capacity to implement locally? Those are key drivers of success as well. So strength of evidence can inform a decision about commissioning. It can never determine a commissioning decision. The commissioner should never just say, I want to pick the highest rated program. Very much as we've said about what works for who, when, there are lots of dimensions on which people might be interested in the variability in the evidence. You might be interested in what works for different ethnic groups, for example, or in different places. We focused on level of need. So when we're talking about the evidence for programs, we've assessed their evidence for a particular target group and for a particular age of child. We don't rate a program that, say, delivers program activities for 2 to 12-year-olds on that whole spectrum if its evidence is actually only about 3-year-olds. If its evidence is only about 3-year-olds, we've assessed it about 3-year-olds. So we've assessed what the evidence says by the age of the child, and obviously as children develop through this period, that matters very much. Kirsten will talk a bit more about some of the findings within those domains. We don't look at the specialists, the more acute end of things in this review. We look at universal programs which are provided for everybody, and targeted programs, whether that's targeted by poverty or features of the external environment, sometimes called selective, or more indicated, where it's based on observed features of the development of the child or the nature of the parenting. It's very important to distinguish those levels. I should mention our evidence panel. Some of them are here. They've been a tremendous support, and of course this work has had many people contributing to it, and there isn't time to thank everybody. So, strength of evidence rating. We have, as I say, assessed 75 programs, and we've given them 2 ratings. We've rated them on strength of evidence, and we've rated them on cost. I'm just going to describe what these 2 ratings mean. Strength of evidence is essentially the assessment of how good is the evidence that the program has that it has been effective. That's a distinction that is quite important between evidence-based, that is to say, there is evidence that the program has been effective, and science-based, which is that it is based on principles which have been shown elsewhere to work. Those things very often get conflated. When we say something is evidence-based, we're saying it's a program, a package of activities that has shown that it can deliver an improvement to child outcomes. The level 4 on this model is replicated programs. So programs that have shown in multiple sites, in multiple times and places, that package of activities can deliver the improvement to child outcomes that it intends to deliver. That doesn't mean it will work every time, and it doesn't mean that it will necessarily work without careful commissioning and careful implementation, but it gives you confidence that the program developers know what they're doing, and they can show that they can deliver impact. Level 3 here is a proof of concept. There's one good study which really demonstrates impact on child outcomes. That's what level 3 means. So the step from level 3 to 4 is very important. But it's also the case that there are lots of programs that are very innovative, they might be very promising, they might be trying things that are very valued locally, and they don't have evidence at these higher levels of 3 and 4. So we've recognized lower levels of evidence where programs might be based on important principles, they might be trying to test effectiveness, but they haven't got there yet. Either because, as you can see, the NE there is a program that has tried a really rigorous study, that has been evaluated in a good study, but found no effect. That's what the NE stands for, no effect. So they have to go back, and they have to go back up through this ladder of learning and testing and adapting. It doesn't mean the program doesn't work. One difficult study which has a finding of no effect does not mean that a program should be completely decommissioned. Otherwise there would be no opportunity ever to learn. It's about testing and learning and adapting. So the NL2 there, level 2 is preliminary evidence, not at the point where we could say the program has proven that it works, but where it is suggestive, it is preliminary. Steps are being taken. And NL2 for programs that haven't yet got evidence at that level. Again, there are some very good programs in the group that we have categorized as not yet at level 2 on strength of evidence. They might be science-based, they might be very, very innovative, they might be trying something very important. Can't rule out a program just on the basis of strength of evidence, But if you want to commission evidence-based programs, then it's levels 3 and 4. And we've expressed that as a journey, as a set of stages, because programs will move up and down this continuum. Family Nurse Partnership is a very good example of that. It had a difficult evaluation in the UK. It doesn't mean we discard it. We have to learn from the evaluation, adapt, and go back through this stage of looking at logic models and then continue. So just quickly, the cost rating, I just need to emphasize, we haven't looked at what you would pay in the market for programs because that is commercially confidential information. What we've done is look at the resource requirements of programs. So a 5 on our scale is a program that lasts for a long time, that has lots of very highly qualified practitioners, that needs lots of license and support and training and supervision and so on. And we've used those inputs to determine a relative cost rating. It's not a rating of market price. What you will actually pay will be negotiated with the program developer. But it gives you a quick, simple assessment of the likely relative cost of these different programs. And they're programs at very different levels of that cost scale in the 75. I mentioned the documents on the website. This is a program report. There's one of these for all of the programs that are rated as NE or 2, 3 or 4 that will be on the website by the end of the week. You can see what the primary outcome is, what the strength of evidence is with an explanation, what the cost is with an explanation, and all of this is to inform the commissioning decision. But there's a very wide array of programs, so thought and care is needed. Just very quickly, I'm going to give you the 4 headline findings before I hand over to Kirsten, who's going to take you through more of the detail under each of attachment, behaviour and cognitive development. Having looked at these 75 programs that, as I say, are available in the UK, there are 17 well-evidenced programs available in the UK. Nobody can say that there are no programs out there that have been shown to work. There are, and they are available. They differ, though. They differ by their approach, they differ in terms of what they're trying to achieve and how they go about it. So there's a menu, which is why care is required and support is required to think about commissioning. It's about what are you trying to do for who, and there are a range of options here. We have found that the evidence is strongest for programs that target based on early signals of risk in child development. There are statistical reasons for that. Obviously, the later in life that you undertake an intervention, the easier it is to measure features of the child. It's very hard to measure child development antenatally in terms of cognitive development, so earlier programs struggle to achieve attachment. Where you're focused on a particular feature of development, programs that are very focused on a particular feature of development have better been able to show change in that feature of development. And where there are early signals of risk, obviously there's further to go. So statistically, it's easier to show impact there, but that is where the impact is strongest. Universal programs struggle to achieve observable, demonstrable change, and there are lots of reasons for that. I'm not saying universal programs don't ever work, or that other forms of targeting don't ever work, but the best evidence is for programs that are based on early signals of risk, targeted to that specific risk in the child. We've also found that the behavioural programs whose primary outcome is around the behaviour of the child tend to have better evidence than those focused on attachment or cognitive development. That doesn't mean nobody should care about attachment or cognitive development. We need development in those programs that are working on attachment and cognitive development. I was particularly surprised by the lack of well-evidenced programs that support the parent-child interaction in the service of cognitive development. Given how important we know early literacy and numeracy are to life chances and how much investment has gone in, and how important the parent-child interaction is as a driver of that, I was surprised there weren't more, so more work to do there. And lastly, as a headline finding, as I say, the case for early intervention is very well made. We've not been assessing that question. The principle that early intervention can transform lives is very well established in the science. The question we've been looking at is, okay, but if you want to do this, how hard is it to implement effective programs? What are the difficulties of practice? And what we found is there are well-evidenced programs, but there's a long way to go. Too few of these programs have evidence across a long time period that follow children through from age 3 development to reduced demand on those late intervention services. We're projecting. We don't have direct evidence. the field needs to continue to develop, and we don't know enough about what works for who when. There's not enough evidence about each program at different age groups for different levels of need, and that will only come from this room. And I'm going to close on that point, that ultimately, as Kerry said in the introduction, we all want more evidence, we all need better evidence, but that evidence has to come from us. It can't always come from somewhere else. And so there is a very positive story here. Early intervention can really make a difference, but to really make it work, we need to continue to develop the evidence and learn from this evidence and test and learn and adapt. Thank you.